So hello, everyone who are just joining, especially those online, because I think those on here in person, everyone remain perfect. We have with us here Marco Greco, President of European Patients Forum. Edward James Smith, Head of EU Affairs, Ministry of the Interior and Health, Denmark. Natalie Moll, Director General of European Federation of Pharmaceutical Industries and Associations. And Katarzyna Piotrowska-Radziewicz, Director, Department of Drug Policy and Pharmacy, Minister of Health, Poland.
Good afternoon.
Thank you all for being here. As we already know from introduction that Natalie Moll made, and also from the discussion that we just had with Deputy Minister of Czech Republic, it's not an easy topic to dive into. So I would like to ask each of you, what in your view is the most significant challenge in balancing patient access to medicines, fostering pharmaceutical innovation, and ensuring robust intellectual property protection in Europe? I'm putting a lot in one. Basically, it's something that pharma strategy aims to do. So in other words, what is the main goal of the pharmaceutical strategy? What should be the main aim from your perspective? Could we start with Poland here?
Good afternoon, everyone. Yes. I can say that it would be challenging during, as Minister said, to finish pharma legislation, especially the incentives part, because I think that this is the most challenging part of this piece of legislation. Well, from my perspective and the perspective of my country, I think that it's more about accessibility to drugs, to medical products for patient, to access. Maybe not so much about the competitiveness. And as Poland's position on pharma and on incentives part is quite balanced, because we know that innovation medical products are very important, are key, because there are new therapies. But on the other hand, new therapies are expensive, and very often they are not available on the markets. For example, in Poland, we have approximately 2.5 years of delay of introducing medical products in our reimbursement system. So, and in some smaller countries, they are not entering in reimbursement system at all. So I think that during the debates, discussion on our working group, I think that this is the most challenging part of this legislation.
Mm-hmm. Thank you so much. We have another country representative here. Edward, what would you like to highlight? What's needed for Denmark from pharma strategy?
I think from our side, we fully agree with the aims of the package. That access has to be improved, and it has to provide medicines for patients that are safe and that they have access to, but it also has to ensure that the industry is competitive, which is also the aim of the package. From our side, our experience is that you have a robust industry providing medicines, and that if you have clinical trials and the research, that in itself improves access. And especially as a small member state with a small language group, it's difficult to get access to medicines, which I think we've heard from the Czech Republic. So how do we ensure that these member states have access, but without the industry, our experience is we will not achieve that access. If we don't have the industry close to us, then the industry will not provide the medicines, because there is a symbiosis between the two. Mm-hmm. So from our side, we see that as being a major issue. But I think as well, listening to what the Deputy Minister from the Czech Republic said, the transparency on where are medicines, what are the availability, issues such as e-labels and things like that, so that we can share medicines between us. Also very important when it comes to access, and then also access to generics. There's just too much of a lag between when the protection periods expire and when generics are made available in many member states. For us, this is this is a priority for us at the BALA system. Ensures that when the innovative protection periods are over, then the generics are there the day after, and that's what we do in Denmark. We would definitely like to see that concept spread more widely so that it'll improve access.
Thank you so much for sharing that. Marco Greco, for patients, what's the most important? What are you expecting from pharmaceutical strategy?
I would try to summarize it into 3 points. The first one is, of course, accessibility, but we need to understand what is accessibility. Accessibility for us means the possibility, the right for the patients to get the medicine that he needs, the right medicine, at the right moment, at the right cost. So there is no sense for us in having a wonderful, innovative medicine if we cannot get it. If we cannot get it when we need, not maybe 2, 3, 4 years later. And the system has to be sustainable, because we work also on the sustainability of the system. We have been growing in an environment in which, as patients, we were being told, you know, healthcare systems are a huge cost. No? So the resources are scarce. That makes mandatory to use the resources in the proper way. The second point is about being citizens. If we are European citizens, if we believe in Europe, as we do believe in EPF, as I do believe personally, there should not be any difference between a patient in Italy, a patient in Poland, in Denmark. It's a no sense that I can get this medicine 2 years before in a country than in another. Where is solidarity? Where is what we are working for when we're talking about Europe? It's all about this. It's simple, and that is why it's very difficult. The third point is that as patients, we need also innovation, because our conditions very often are running faster. Conditions are very often already faster than the innovation. And the innovation is always following. Unfortunately, we are not in the technological capacity of anticipating, but we are still running after. So we need innovation, and that's why we need a system that has to be balanced. We recognize the fact that we need resources for granting innovation. Innovation has a huge cost, of course. But on the other end, if we talk about innovation, we need also to consider one basic point. If it doesn't get to the patient, it's not a real innovation. Because if I have a cure for my condition, but it's available only, I don't know, in the United States, then it's not a cure. I don't have a cure in that moment. Mm-hmm. That is as simple as it is.
Thank you for sharing that. And Natalie Moll, what are you expecting from pharmaceutical strategy as you're representing pharmaceutical industries and associations?
Thanks, Deirdre. I was just thinking about what you also said at the beginning, you know, what everybody's expecting out of this piece of legislation. I was looking back in time. So discussion on access really started at the level of member states together in 2016. There was really a big discussion around why is the access so diverse? Is it because of incentives? Let's have a look into that. And that was before thinking about revising the legislation. And I think that it is too simple to try and use European legislation to fix an issue of access in 27 member states. So I'm not saying there is no place for it. I'm just saying I would hate for us to finish negotiations and think, okay, we've dealt with access, that'll be fine by now. I really don't believe, from the evidence that we have published year after year for the last 4 years and the measurement of time it takes for medicines to reach patients, that it is as simple as that. And as I said in my introduction, I really think it's on all of our shoulders to take access much more seriously than a piece of European legislation, sit together as healthcare industry, patients, hospitals, doctors, member states, commission, and see what the problems are. I'm going to give just 3. So So this is access. I'll talk about access in a second. But for me, what I'm really looking for in this legislation is an updated, future-proof piece of legislation, because this is a 20-year-old piece of legislation to approve and incentivize medicines. We are behind other parts of the world tremendously. 20 years old, with the kind of science that Marco was talking about, is outdated incredibly for today, never mind for the next 20 years when this legislation is going to be in place. So what industry was looking for and hoping for is, great, we're going to have updated legislation that's going to be super attractive, and despite us being a collection of 27 countries, 27 markets, etc., we will look attractive because of our legislation. And today we even hear that the regulatory updates, what was really the most important thing in the package proposed by the Commission, are under discussion by different groups. And that's really concerning, because we won't get access and we won't get a future-proof legislation. So what are we getting? We're just going to get a worsening of the situation. That's very concerning. So I would say, first and foremost, updated future-proof legislation that can deal with the innovations of today and the ones coming in the next 20 years. Incentives in the right places, including for antimicrobial resistance. We could be the first region to have incentives that really pull through new products. And then let's think about access more seriously as a healthcare community in a very specific way and with a plan and with responsibilities.
Thank you for sharing that. So let's stay a bit on access part. So between 2019 and 2022, the European Medicines Agency approved 167 medicines. As of January 2024, the European citizen born in Germany had access to 147 new treatments, so just 20 less than were approved in total. In the meantime, European citizen, but living in Malta, was at the end of the scale with only 6 available. My fellow Lithuanians had 14, so 10 times less than ones living in Germany. Obviously, there is an error somewhere here, right? So I would love to hear from patients, because ultimately it is about patients not reaching the medicines. So how do you see the situation, and how do you think pharmaceutical strategy could solve it? Like, what Commission proposed, it was to reduce regulatory data protection baseline, and then award extra 2 years if the medicine is, at least as far as I understood that there are talks with a country to launch the medicine there. So do you think this is a good approach? Is this the way to go? And would it change the reality of patients?
We hope it could change the reality for patients. My fear is that it could be a bit more complicated than this, but at least it's something. It's a step in that direction. We may discuss about the mechanism of how this incentive will work or not. But still, I mean, the point is, that linking the accessibility in all the states, or making mandatory, let's say, to sell the product in every country, to 2 extra years of incentives, it's a way, but at the end of the day, it's not a true guarantee that this will happen, because a company following other interests, like market laws, for example, can decide to say, we step back. So in the end, we need to face these. It's interesting in this perspective, the recent proposal of the Parliament, that try to give a different angles, moving it on the choice of the national states to decide if to ask for it or not. Although it's not very clear to us what happens if they ask and they don't get, or what happens as patients if our national state decide not to go for it. Because the point is, what is the mechanism has to be transparent. That's the key message. And as citizens, we want to understand what is the reason behind a certain choice. the choice of not applying for this or the choice of not selling in that country. It's clear, if you ask me, my mandate is clearly to ask for having the same drugs, as I said before, no? In every country, in every European country. If I am a European citizen, I don't have to travel for buying drugs, for getting the drug that I need.
Okay, so staying on this so-called launch conditionality, the European Commission's impact assessment report by Technopolis anticipates that this reward of 2 years would lead to a 15% increase in access to innovative medicines associated with 444 million euros gain for payers and patients. I went to EFPIA's website as well, and EFPIA said there that it plans to include committing to file pricing and reimbursement applications in all EU countries as quickly as possible and no later than 2 years after receiving the EU marketing authorization. So basically, it seems that industry is also willing to reach out to countries, and it kind of aligns, or doesn't it? How is it like?
Yeah, no, that's a really good question. So I think there are two things. The impact assessment on the RDP reduction, because it's not affording 2 extra years, it would be giving back the years we already have today in a situation where we've lost R&D investment to the tune of 25% in the last 20 years. So you have a reduction in R&D investment, Europe's less attractive. What are we going to do? We're going to reduce incentives. That's completely counterintuitive to making the region more attractive, right? That's just the opposite. If you want more innovation and you want things to get better, you don't reduce incentives. So the two don't go together, and the calculations that we made in terms of reducing RDP, I'm going to give one example because there are so many, but for 10 SME projects in advanced therapies, for example, only one would survive if we only had 6 years of RDP. There are lots of other things. There are 16 million years of life lost. There are lots of other examples of the reduction of RDP, but I'm just saying I think the proposals, again, are perhaps not looked at in their entirety in that sense. Our commitment, on the other side, was because we couldn't get the discussion that I was talking about at the beginning, where all of us sit together and agree what the problems are in access, and then who does what. We couldn't get that discussion, so we said, okay, fine, you know what, we'll do our part. And what we committed to was indeed to ask for filing and reimbursement in all 27 member states within 2 years of marketing authorization. But it wasn't only that, we also are tracking that commitment to see what's happening. So when we make that commitment, what happens? And I have an example, for a few countries. There are problems of access in Greece. You can't start a pricing and reimbursement discussion until 5 out of 11 countries have got a price, for example. In Bulgaria, you can't finish it so every January you have the listing of new products that are allowed, that are reimbursed, but it happens every January. So if by any chance you get an agreement in February, you have to wait until the following January to be listed. In Italy, you get a price for the whole country, but it can take 733 days to get it declined in the 20 regions. So you see those 2 years that are in the legislation are completely unpredictable and practically impossible to reach. But the commitment from our side is there to do our part, and then the other side has to do their part to meet the needs of patients as quickly as possible, which would be ideally less than 2 years, right? And this is a little bit the situation that we're facing, trying to fit something into a piece of European legislation that is exquisitely national and subsidiarity principled, is being disingenuous and will harm innovation. And then, as Marco said, if you don't have innovation, you don't have products. If companies see that the conditions in Europe are even less attractive than they already are today, it won't be possible for them to do innovation here. And then what access do we have? I think we need to fix the right things with the right tools. Update the regulatory system, make sure we have the right incentives, make sure that they fit with what Innovation Europe wants, and then fix access together in all its multifaceted ways. And I know I sound like such a broken record, but I still am very optimistic that we can do this because we're still talking about it. So,
thank you, Natalie. I think what Marco was also saying, even if we have a product, but it doesn't reach the patient, we don't have an innovation.
Exactly. Yeah.
So this is also important point. And I love what you're bringing. I hear what you're saying, that it's not only pharma's responsibility, countries also play a role. So we have representatives from 2 countries. That's great. Let's start with Denmark. Denmark, country of nearly 6 million people, and while population-wise you're not the biggest country in the European Union, you have actually a lot of accessible drugs. You have 109 medicines approved by the EMA as of 2024. So you're behind Germany, Italy, Austria, and Switzerland. So Edward, I would like to ask you, how do you ensure access for patients in Denmark? And how do you see the role of industry, and what's the role of industry and the governments in ensuring access for patients?
Well, I mean, of course, there are a number of reasons why we have access, and one of them as well is that there's a willingness and an ability to pay as well, and we fully recognize that Denmark is also one of the wealthier member states, and that of course plays a role. But as I said before, as a small market and a small language group, there are still major barriers, and one of the main reasons why we have access is we have firstly a strong pharma industry. We have a strong research community, and we have a lot of clinical trials being carried out in Denmark. Per capita, way more clinical trials than any other member state in the European Union. If you have a country where a lot of clinical trials, our experience is that the medicines that are tested and approved through these processes, they need to be marketed in that country. This is one of the reasons why we have to ensure that other countries believe that they are worth marketing or buying. So this is one of the reasons why Denmark has strong access, despite its size, is that it's very much a clinical laboratory for a lot of pharmaceuticals. We also have it's easy to market your product in Denmark. This is one of the reasons as well. We have quite a efficient bureaucratic system which allows for relatively quick reimbursement processes, and this is also one thing that makes it attractive, is our understanding from our. We also only have one buyer for, at least for hospital products in Denmark. There's only one buyer. It's not per hospital or per region. It's one buyer for the whole country. Which helps us be a little bit bigger than we are, and but it means there's one point of contact, which also makes it more simple. But there are a number of reasons, some of which cannot be fixed in the pharma package, and some of which can be. And we believe that the decision to market a pharmaceutical in the end is an economic decision by companies, and reducing the protection period, and then deciding, is it worth going through that to get to 8 years, or do we just go for some markets and then reimburse by making it more expensive? That is going to be the end result of reducing the data protection period. It's not necessarily going to provide the access which we are looking for. We feel that there should be a lot more focus as well on how do we work together to ensure access, how do the member states pool their resources, especially the smaller ones, with joint tenders, with providing more transparency on who's actually got these medicines. And generally the market in Europe is very fragmented. There's very little transparency on how much is this person paying and how much is that person paying, and why have they got them and why have we not got them. This is a serious barrier as well, we feel, for access, especially for smaller member states, is the lack of transparency in pricing and in the market access. Yeah.
Just to make sure, so is Denmark against reducing a regulatory data protection baseline?
Yes, we are against it. Yes.
You want to keep it at 8 years?
We would like to maintain it at 8 years. We don't feel that the modulating it will provide the results that the Commission was hoping for, and we see that the way the negotiations are developing, we feel that this is definitely not going in a direction whereby you'll provide any access at all. You'll just provide more bureaucracy and more hurdles.
Perfect. We will go back to this point a bit later. I just want to hear from Poland's perspective. same question, however, just a bit of background. Poland, in contrast to Denmark, has way less medicines accessible, only 6 to 9, opposed to 109 that I mentioned before, despite being the 5th biggest country in Europe population-wise. So why is it so? How is it going with clinical trials that were mentioned? You know, are you able to attract companies as well, or what are the reasons that you see?
I think that is a hard question to answer because when it goes to our reimbursement system, it is very open. Each company can apply voluntary. And actually, I don't know why is it getting like that. Poland, that's why Poland is during this work on pharma legislation is support reducing RDP because we need more generic products entering to the market and of course entering to our reimbursement system. I would like to give some overview concerning the price, which is, as you said, for Poland very important because we are a big country but not as wealthy as Denmark is. So in Poland, we reimburse 133 medical programs, and these programs are innovative drugs. I think that this is quite a good number. And as an example, I will show you how much cost, for example, reimbursement of the program of breast cancer. This is 238 million euros. Cancer for a drug for lung cancer is 247 million euros. From our perspective and from perspective of our national fund, this is a huge money. And on the other side, we have generic products, and because of that, for some like drugs such as trastuzumab, 73% decrease of price. Rituximab, 61%. Bevacizumab, 77%. They're all cancer drugs. So as you see, thanks to the generic products, we have money to refund for our Polish patient innovative medical products. That's why Poland is it so strongly supports this regulation to cut RDP. And the second thing is, well, I think that it's not really affected the competitiveness. This part of legislation. Europe has really strong RDP system. It's, I think, when we compare it to US, Canada, Australia, or China, it's one of the better. So it's increasing since 90s, and it doesn't affect R&D as much as we think. So this is our position. I think that our responsibility as a government is to give a patient equal access to medical products, not only in Poland but also in all European countries. And this is goal of the Polish presidency.
Mm-hmm. Thank you for that. So we already mentioned several times the reduction of the baseline protection of regulatory data protection. So there were some countings done by the European Commission. Again, Technopolis report found that the baseline reduction of data protection by 2 years would reduce annual costs for public payers by 1.13 billion euros and stimulate the generic market with an additional profit of 266 million euros per year. However, then we got another report that found that reducing data protection may lower the return on investment for innovators with potential spillover effects on research and development spending and access to pharmaceutical innovation. So a report by Copenhagen Economics found that countries with RDP incentives have higher access to existing medicines and clinical trials. I think this is something that Edward was mentioning before. So we have, two opposite views. And I would like to hear from Natalie, how can the strategy better address the challenges of ensuring access to affordable medicines without disincentivizing innovation? Because you were saying that the way the Commission wants to go is kind of this, basically making matters for worse for industry.
Yeah, so again, and I think, what I was saying at the beginning, we're all responsible for access, and the temptation to try and fix everything with a revision of legislation, for me, is what is really wrong here. There's really an attempt to say, I'm going to reduce RDP, that will make biosimilars and generics come in first, and then I'll give it back if they go in countries. It's a bit of a mix of ingredients that is not going to create the cake that we're hoping for. And this is where the simplification, if you look at Japan, increased its RDP from 6 to 8 years, and within 2 years, its clinical trials increased by 160%. So it's exactly the 6 to 8 years. And you said it as well, countries that have higher RDP have 3 times more access than others because of the innovation element. But again, it's the struggle in this piece of legislation to, do we do innovation? Do we do access? Do we do this? Why are we doing that? This piece of legislation is so important because our regulatory environment is not up to date, it's not attractive, it's old, we need to update it. Why are we not focusing on those elements and on creating incentives for new areas like antimicrobial? And why are we desperately trying to fix access in here? I don't understand. From all the data that we've seen, our innovative attractiveness has reduced. We've lost 25% of global investment over the last 20 years, not just last year, last 20 years. If you want to stop and reverse that, if you want to make Europe attractive to innovation so that you can have the generics afterwards, because if we don't have innovation, we also don't have the generics in 10 years. So if you want to keep that ecosystem going, the last thing you want to do is reduce the incentives. You want to see access is a huge issue. Why are we not looking at it as seriously as we're looking at incentives? Why are we trying to fix it in a piece of European legislation? I don't understand. I gave some examples of some countries, but there are other things. There are HTA requirements. There are healthcare systems in countries that didn't have clinical trials who just cannot welcome a new kind of innovation because the healthcare system is just not set up for it. I don't know, CAR T cells, lots of ATM, advanced therapy medicinal products. Why are we not investing into healthcare systems updating? Why aren't we looking at the MFF for things like that? I think access is so much broader than a small 2 articles in a piece of legislation. And I certainly feel the responsibility for going broader than just that. There's prices, there are differentials, there are so many different aspects we need to look at, and risking the innovative power of Europe or stopping that decline and reversing it in an attempt to fix something that is national and a piece of European legislation, for me is exactly the wrong direction to go, which doesn't mean we don't address it.
Okay, thank you so much. This session has an option for our audience to ask questions. So please, whoever has a question, raise your hand. If there is no hand right away, I have some questions before you warm up. But looking around. Okay, so before our audience is thinking what to ask on this broad topic, just because we have a chance to have our next presidencies, actually, Poland and afterwards Denmark. I would love to hear from both of you very shortly, like just in a few words, so we have time actually for questions as well. But what are you going to focus on pharmaceutical package during your presidency? What will be the main challenges in 2-3 words?
Well, main challenge, I think that we can get it for our discussion. It will be, I think, incentives. And as I said before, this is the most challenging part of pharma legislation.
Perfect. Thank you. You don't have to go deeper. We will get a chance. Edward, what about you?
Yeah, I think that the biggest challenge of this is it's a very complex file. It's a very political, and as the presidency, to try and put one's own interests a little bit to the side to find the compromise in the council. Otherwise, it's never going to finish.
Yeah, it didn't seem that finding compromise is an easy task, at least
Very
from
difficult.
the discussions that we saw so far. Are there any questions now? I see the hand over there. There should be a microphone available. There, far corner. If you could present yourself, please, and tell to who you want to direct the question.
Yeah, so maybe I'd like to direct this to the two government representatives. So I think the key question in this pharmaceutical legislation is, are we going to have more equity of access across the European Union? It was discussed by the patient representative, by Natalie as well. But I think part of the challenge with the modulation of data exclusivity, so for example, if a product wasn't marketed in Central and Eastern Europe, but it was in Western Europe, is that there would be a fear on the part of the pharmaceutical industry that external reference pricing would apply, and therefore a special, maybe lower price for Central and Eastern European countries would have a rebound effect on prices in Western Europe, in the United States, and the whole world. So would a trade-off not be possible in this, to have the modulation of data exclusivity and some solution around external reference pricing? Because this is the real fear that makes this question so difficult.
I'm not going to try and answer your question because it's quite complicated, and I think more a question for industry on how. I think for us it's important that the market is more transparent. And why is the pricing so different, or should it be differentiated? We're not sure. But for us, we think that the fragmentation of the market itself is a problem, and that there should be more transparency in how prices are set. I think it's, as our understanding, it's quite basic economics, is that transparent markets will often produce better price setting. But maybe the industry can help us on that.
So, well, one of the other proposals that we put forward when we came up with our commitment to file was also something called equity-based tiered pricing, which was making products available to countries at the price that they could afford, depending on their needs as well, because it can also be a different disease pressure. But for that, as Adrian was mentioning, there are a number of things that happen at European level, which is either external reference pricing or products being exported from one country to another as soon as there's a price differential, which makes it difficult to actually create access, even though you've tried to sell the product at the price that the country can afford. So again, and I'm like the biggest broken record of history, if we sat together and discussed, because what Adrian just put on the table, that's something that we would need to sit down and discuss somewhere and agree, well, what is it? How could we do that? What could you work? I mean, it's difficult to do a trade-off in a legislation, right? You would really need to put that in a basket of solutions for access and see how would you even do that. We have an internal market. How do you stop external reference pricing? How do you manage movement of goods? And these are really important issues because you have the willingness of the industries, both mine, Innovative, and Adrian's, who is the generic industry, to increase access. Because for us as well, an innovation is not an innovation if the patients don't get it. What is the point of making products if you can't sell them and patients don't have them? That's the whole idea, right? So I think, again, a reason to really sit together. And the problems are not at the member states only, or at the industry only, or the HTA only. They are so varied and differentiated that we would need to find solutions for the different markets. And a discussion on that would really be welcome.
Perfect. I saw that, Marco, you would like to comment on that.
Just a quick comment, because the question was for sure very interesting and demanding to some extent, but also gives me the possibility of maybe giving a slightly different perspective. That is, I fear that the discussion on RDP is focusing a bit too much on RDP per se, on those 2 years, rather than the fact that the Commission idea in background was to try to solve a problem. This is a proposal, of course, and it's interesting, and it has the value at least of attempting and having a wider, for us, for example, for me, it's a pro, the fact that it has a wide view. Clearly, it takes some difficulties. And the difficulty is that if we focus on my opinion is that if we keep on focusing on those 2 years per se, not linking these to what are the problems around, we risk to have a sterile discussion, no? Because, I mean, I've been asked several times what is the opinion of patients. The opinion of patients is the necessity of getting the drug, as I said at the beginning. So it's not negative per se towards RDP. It's negative is if in exchange nothing is given back in terms of concrete accessibility and concrete improvement for the life of patients. I think that is the way, the angle we need to give to the discussion. So how can we solve the problem? And connected to that, so that's why, per se, the idea of saying, okay, we can keep these 2 years with something in exchange, in principle, it's not negative. Maybe we need to better focus how it works, because I agree on one thing that Natalie said. We cannot probably rely on this entire mechanism when an important part of this mechanism depends then on what happens on a national level, that it's out of the control of the majority of us in this moment.
Thank you so much. I'm sorry, I will have to wrap it up because we're running out of time. Thank you so much for all the speakers. Thank you for our audience. I think I would love to finish with Health Commissioner Stella Kyriakides' words when she said that it's certainly the most important, but also one of the most sensitive files of the last decades. And I think we can feel it here today. There is no quick fix, no quick answer. And there's a lot of efforts that are needed from all of the stakeholders involved, from countries and industry, to solve the issues that we see today. Thank you so much. And now I invite you to stretch your legs, because we will have a networking session.
Thank you.
Thank you so much. Cheers.